Welcome to iForum RX, where we explore the evidence that informs ambulatory care pharmacy practice. Today we'll be discussing the manuscript entitled Efficacy and Safety of Canagliflozin versus Glimepiride in Patients with Type 2 Diabetes Inadequately Controlled with Metformin, which appeared in The Lancet, September 2013. Today's presentation will be given by Amanda Chartel, the PGY2 ambulatory care pharmacy resident at the University of Maryland School of Pharmacy.
In March 2013, the FDA approved canagliflozin, or Invokana, the first agent in a new class of oral medications used to treat type 2 diabetes. This new drug class is known as the SGLT-2 inhibitors, or sodium glucose cotransporter 2 inhibitors. In January 2014, another SGLT-2 inhibitor, dapagliflozin, or Farxiga, was approved by the FDA. Other SGLT-2 inhibitors, such as empagliflozin, are currently in the research and development pipeline. Given the creation and rapid expansion of the SGLT-2 inhibitor class, it is important to evaluate the role these new medications play in the management of diabetes. Over the next few minutes, we will review current diabetes management and how the SGLT-2 inhibitors work, examine the design and results of the CANTATA-SU trial, and discuss how this evidence impacts patient care. Historically, clinical practice guidelines have supported the use of metformin as first-line therapy for patients newly diagnosed with diabetes. However, when patients fail metformin monotherapy, it has been less clear which agent to add to the patient's regimen next, given the multiple alternative therapies available. Typically, clinicians must compare the A1C lowering potential, additional benefits, adverse reactions, and cost of oral and injectable therapies in order to make a decision. As we can see from this diagram, this is the approach supported by the American Diabetes Association in its 2014 Standards of Medical Care in Diabetes. While the SGLT-2 inhibitors have been approved since 2013, the ADA did not comment on their role in therapy in this year's standards. In contrast, the American Association of Clinical Endocrinologists did include SGLT-2 inhibitors as options for monotherapy, dual therapy, or triple therapy in their 2013 diabetes management algorithm. They do note that this inclusion into the algorithm was only based on Phase 3 clinical data at the time of publication. Like the ADA, the AACE recommends weighing the risks and benefits of the different classes of medications in relation to patient-specific factors before making a decision. Before we review the CANTATA-SU trial, it is important to understand how the SGLT-2 inhibitors work. Normally, the kidneys regulate glucose in the body through sodium glucose cotransporters. SGLT-2 is found in the proximal tubule and accounts for 90% of the glucose that is reabsorbed in the kidneys. SGLT-2 inhibitors work by blocking renal reabsorption of sodium in the proximal tubule. This action, in turn, inhibits renal reabsorption of glucose as well. Urinary glucose excretion then increases and serum glucose returns to more normal levels. Due to its renal excretion, use of canagliflozin is contraindicated in patients with a creatinine clearance less than 30 milliliters per minute. There is also limited data suggesting a benefit in patients with creatinine clearance less than 45 milliliters per minute. Now that we understand how our SGLT-2 inhibitors regulate glucose in the body, let's begin to understand the efficacy and safety of these agents so we can determine their role in the management of diabetes. The CANTATA-SU trial was designed to do just that. Researchers wanted to compare the efficacy and safety of the SGLT-2 inhibitor canagliflozin with the sulfonylurea glimepiride as add-on therapy in patients with type 2 diabetes inadequately controlled on metformin monotherapy. The study enrolled 1,450 adult patients with type 2 diabetes and a baseline A1C between 7% and 9.5%. Patients also had to be on stable metformin therapy of 1,500 milligrams to 2,000 milligrams per day for at least 10 weeks prior to the study. Patients were excluded if they had a history of severe hypoglycemia, repeated fasting blood sugars over 270 milligrams per deciliter during the pretreatment phase, or decreased renal function. Subjects were randomized to receive either glimepiride, titrated up to 6 or 8 milligrams daily, or canagliflozin at doses of 100 milligrams or 300 milligrams daily, in addition to their stable metformin therapy. Subjects were followed for 52 weeks, and changes in A1C and weight, as well as rates of hypoglycemia and other adverse events, were recorded. Baseline characteristics between the groups were similar. The average patient in the study was 56 years old, had diabetes for 6.5 years with an A1C of 7.8%, and weighed 87 kilograms with a BMI of 31 kilograms per meter squared, indicating obesity. There was a relatively even distribution of men and women in each group, and the majority of patients were Caucasian. Additionally, rates of discontinuation between the groups were similar. After 52 weeks of follow-up, both doses of canagliflozin were shown to be non-inferior to glimepiride in A1C reduction. Canagliflozin 100 mg and canagliflozin 300 mg lowered A1Cs an average of 0.82% and 0.93% respectively, compared to 0.81% for glimepiride. While canagliflozin 300 mg was found to be superior to glimepiride for A1C reduction, it was only a 0.12% difference in average A1C, which is not clinically significant. In comparison to glimepiride, which increased body weight at 52 weeks, both doses of canagliflozin significantly reduced body weight by about 4.5% at the end of the study. Patients in the canagliflozin groups lost around 4 kilograms by the end of the study, most of which was fat loss. Rates of hypoglycemia were significantly more in those patients receiving glimepiride compared to either of the canagliflozin doses. Additionally, rates of severe hypoglycemia, defined as an event requiring assistance of another person or resulting in a loss of consciousness or seizure, were higher with glimepiride than with canagliflozin. However, rates of severe hypoglycemia were low in all groups. While hypoglycemia was more common with glimepiride, there were certain adverse effects more frequently associated with canagliflozin treatment, including genital yeast infections, urinary tract infections, and increased urinary frequency. These findings generate a number of questions for discussion. In particular, what are the strengths of the CANTATA SU study? Are there any potential weaknesses that threaten its internal or external validity? What are the potential advantages of the SGLT-2 inhibitors? Is there a way we can predict, prevent, or mitigate the adverse effects of the SGLT-2 inhibitors? And other than cost,